to our webinar today. And get my slide screen started here. All right. Welcome to the Center for Interdisciplinary Health Workforce Studies' 2015 webinar series. My name is Christy Friedman. I'm the program manager here. We're pleased to have you all joining us for today's webinar. This is the final event in our spring webinar lineup, and this one will focus on new research and insights regarding trends of the medical assistant workforce. A few center announcements before we continue to make you aware of. First, we have released first quarter 2015 data on characteristics including employment of the RN workforce. Be sure to check out our website for more information about that data. Also, would like to mention that we're sending out a monthly newsletter called Centerpoint that details recent research, information, and news about our center and the workforce community. If you haven't been receiving this and you would like to, please let me know and we will get you on the list. Archived newsletters are also available on the website as well. Finally, we would also like to mention that we are partnering with the National Forum of State Nursing Workforce Centers to host their annual conference, The State of Nursing Workforce in an Era of Healthcare Reform, Data, Trends, and New Collaborations, that will be held June 10th through 12th, 2015 in Denver, Colorado. We anticipate this conference will be a powerful event bringing together state-level nursing workforce center efforts and leading researchers in the field of nursing workforce to share insights and to develop key objectives, collaborations, and strategic planning as we move ahead in this dynamic era of health reform. The conference is right around the corner and registration deadline ends on June 4th, so see our website for more details if you would like to attend. We intend to allow for discussion time of about 15 to 20 minutes after our speakers conclude their presentations. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many as we can. We are also recording the webinar today, and we'll have it posted to our website at Health Workforce Studies, that's all one word, healthworkforcestudies.com, and we have posted all of our previous webinars to our website if you missed any of our previous events. You can also find presentation slides posted within the event calendar as presenters allow. Today we have a great presentation focusing on the medical assistant workforce. First, our presentation will be given by David Auerbach. Dr. Auerbach has a PhD in health policy from Harvard, where he was a principal analyst at the Congressional Budget Office, and he did research on modeling, including analysis of the Affordable Care Act. He was then at Rand Corporation, where he worked on healthcare workforce issues, primary care, military health, and accountable care organization research. He's speaking here today as adjunct faculty for the center, and he will be discussing recent research that focuses on findings from an upcoming center issue brief, Volume 1, detailing data on employment, wages, work settings, and regional distribution of medical assistants. This issue brief is the first in a series of periodical releases of in-depth details about the workforce, and the full piece he will be discussing is available now on our website. And with that, I'm going to get Dave's presentation pulled up, and we'll get started. Dave, when you're ready.
Okay. Thanks, Christy, and thanks to those of you who are attending. This is very exciting. I'll just open by saying that, as you might have gathered from the introduction, a lot of the work that we've done through the center has been focused on the nursing workforce. And we felt that, well, it is an interdisciplinary center, and no health profession really works in isolation. There are overlapping roles, and especially as the healthcare system changes and transforms, we felt it was really important to understand how different professions work together and how their roles might be shifting as the practice of care shifts. So with this work, we decided to focus on medical assistants. It's an area, it's a profession that not a lot is known about, and in this talk we're taking advantage of the fact that the American Community Survey in 2010 started identifying medical assistants specifically, and they had not before. So now we have 4 years of data to work with, and there's a lot that we can learn from that. So I will be showing fairly descriptive overview sort of information from that data source, combining it with other data in some cases, to just help us get a bit of an understanding of what have medical assistants been doing, where are they located, their wages, and some of their roles, and to see if their roles are indeed shifting as care delivery shifts. And I will be having Christy advance the slides. Okay, ready.
Oh, 1 second.
Okay.
There we go.
Hopefully that works. Okay, great. So this slide, let's talk a little bit about what medical assistants do and have done. In the tradition, we've probably all encountered medical assistants as we go to offices for checkups or other things. They've done a lot of administrative and clinical work, scheduling patients, billing and coding, interacting with other more other forms of care, hospitals and so on, taking patient history, preparing for an exam, the kind of things that we see all the time. And as payment systems and as we expect different things from primary care especially, for example, care coordination, as you start to expect practices to manage the total cost of care or care across the continuum, somebody has to do some of that work. And in addition to physicians and registered nurses, practices are finding that medical assistants can play a lot of these care coordination and management roles. And some of these roles include acting as health coaches, tracking patient adherence and immunization, pre-visit chart review, flagging overdue service or care gaps, leading team huddles, making outreach calls. All things that we're starting to see medical assistants do, especially in some of the more advanced or practices that are taking on risk, where now you have some additional funds to work with that are not necessarily tied to a fee-for-service visit. So some of the former roles have been engineered around how can we maximize fee-for-service visits. Now you're finding practices place a greater value on some of this stuff that kind of fills in the gaps of care. Okay, next slide. So one question we wanted to ask was, with the data, well, do we see evidence of this shifting role? And in this slide and in one coming up, I would say the answer is sort of yes, sort of no. First of all, let's just look at basic overall characteristics. You see that the number of employed medical assistants, and I'm just showing 2010 and 2013, although we have the middle years, there's been a growth. I'm highlighting in the green about 15% growth apparently just in these 4 years, which is pretty big. That's a lot of growth for a profession. You also see that the earnings have not really grown. Now it's a little bit a factor of the economy in general, where wages, and particularly wages for folks without a full college degree, have not been growing over this period as well. So it's a little hard to tell, but it's certainly true. We might have expected more growth in wages if there was greater demand for folks in this area. I also might have expected a shift towards physician offices. We don't see that in the data. It looks like the sectors where medical assistants work have stayed pretty much stable over this period, with about a 2-to-1 ratio of working in offices of physicians versus in hospitals, so the top two. And then you find medical assistants in outpatient care, other health services, and then a small smattering in some other sectors that are not noted here. Okay, let's have the next slide. So perhaps mixed evidence of a shifting role. But then one thing that we looked at that is a little bit more suggestive is what we did was looked at over the 4 years of data that we have, and I apologize for the y-axis, it's truncated here, so we're looking at average annual earnings, and here showing starting at 20,000 on the axis. What you do see is that although earnings dropped on average for all medical assistants, it looks like those working in physicians' offices were pretty stable over these 4 years. They kind of held steady, while those working in the hospital do look like there was a drop. So relatively speaking, it could be that there is some evidence for this enhanced role within the physician's office setting. Not to say that medical assistants can't perform some care coordination in hospitals, but that would primarily be a physician's office role, where that's where a lot of the risk is in ACOs, and then global payment models. Okay, next slide. Then we wanted to look a little more in depth at some of the demographic characteristics of the workforce who are medical assistants. And here we're doing a few things, comparing them to RNs just as a point of comparison from the same ultimate data source, and then showing how some of these characteristics actually affect earnings. And that is from an earnings regression that you could find out more about if you were interested, and that's described a bit more in the paper. So age, here you notice right away, medical assistants are young. There's about more than half that are under age 35 compared to just about a quarter of RNs at that age. So partly that reflects fewer educational requirements, less years in school, but it also seems to suggest that there has been a strong growth of young people going into this profession. And not surprisingly, very few are over age 50. You also see in the column on the right, though, those who are older earn quite a bit more. I mean, on a base of $30,000 a year, you're seeing those over age 50 earning on average about $10,000 more, and that's a big difference. So there could be some returns to experience in this field. Most medical assistants are white, as are RNs, and a very high predominance are female, 94%. Very much a female-dominated profession. And as for the amount of education medical assistants have, there's a lot of variation. A fair number do not have any college experience. The plurality have some college, but not an associate's degree. Most of the programs for MAs are something like 1 year, maybe up to 18-month certificate sorts of programs. Some of them don't even award a formal certificate, but have a large degree of on-the-job training. So there's not a lot of regulation or standardization in medical assistant education. Some have associate's degrees, and around 9% have a bachelor's degree. And also comparing the earnings of those, you see that there is a response to higher education, but it is mostly among those with the bachelor's, where you have a significant earnings bump for those with more education. And that, again, could be reflective of the fact that in a fairly unregulated, unstandardized profession, there's a lot of latitude. And if you're somebody who has a higher amount of education, they probably are playing a more valuable role. Of course, it's not always true. Okay, next slide. Then we tried to see if we could understand a little bit about, okay, a lot of these roles that we've described do overlap with some of what you might expect a licensed practical nurse to do, an LPN, or even an RN. And we wanted to see not only how much do the number of MAs vary by different regions of the country, but are the areas where you have a lot of MAs, do you also have a lot of LPNs, or are they sort of acting as substitutes for each other? And you see what really struck us, a very strongly negative line here, which means the areas of the country with a lot of MAs have few LPNs. For example, in the New England and the Pacific region on the right, and you see the key on the right of this slide, those areas have more than 200 medical assistants per 100,000 residents, the highest amount. They also have among the lowest amount of LPNs, and vice versa. In the East, South, Central, on the left of the graph, very few MAs and a lot of LPNs. So there are certainly deeper, more rigorous analyses that could be done that we might do in the future, but this is suggestive that there are overlapping roles and that some areas are favoring one type of worker over another, which we don't really have a sense of why that might be. We also did the same cross-sectional sort of analysis with RNs, and there also, even with RNs, seemed to be a very slight, there was a negative relationship as well in the same way, but it was weaker. So hard to draw a definitive conclusion, but again, there could be some sort of substitution going on. Okay, next slide. So then as we started thinking about, well, why are some areas using twice as many MAs as other areas? Is there anything behind that? And again, though we don't have very strong evidence, one thing that we thought about was, well, do they have different laws that regulate or govern what MAs can do? And we did some some research and discussion of that, and the laws do vary. And it's hard to know how much this really matters, but just to describe, there are different ways that states, and this is a state level thing, talk about what medical assistants can and can't do. And in some cases, they have broader laws that apply to not just medical assistants, but all, and you'll see what they're called, unlicensed assistive personnel. Sometimes it's sort of a blanket regulation that just that says they can or can't do certain things. So these 4 regimes of laws that a state can have, well, they're grouped in this way by a paper that I'm citing on the bottom. He grouped them in these 4 ways. Probably the most, at least in his opinion, this is kind of ordered in the most permissive states that have an express recognition law that names medical assistants and says, we recognize this as an occupation, as a profession, and here are the things they can do. And about 1/3 of the country lives in a state that has that kind of law. And then you have, in the middle, you have different kinds of regimes. For example, delegation, which says a number of states say, well, it's pretty much up to the physician or maybe a nurse who are supervising them to decide what they're allowed to do. And that's a fair chunk. And they have somewhat, it's hard to know in which case can the MA do more, the first or the second. It probably varies. So it's a bit hard to tell. But they're generally not named specifically in the second or the third category. The third category is similar to the second, but it says, it's kind of similar. It says, well, we are going to say normally to, let's say something that MAs typically can or can't do depending on the state law is give injections. And some states might have one law that says you need to be licensed to give an injection. But then they'll have a new law, this exemption situation, which says, except in a case where if the physician is going to delegate to a helper, an unlicensed assistive personnel, then that licensure requirement doesn't hold anymore. So the doc can override the licensure law and say, yes, you MA, you can give injections, and it's any liability or anything like that is up to me. So there's a number of states that have that kind of regime. And then in the last category, there's a number that really don't say anything either way about it. And 18% of the U.S. is in that case. So for my last slide, I'm just going to show we then went back and counted the number of MAs per population in each of those types of states. And this was not something that we might do in the future is control for other variables, because sure, there could be different other reasons that these states differ. But just doing the simple relationships, looks like there are more MAs in those states that have perhaps the more favorable sorts of laws, the express recognition. And you see this pattern. Although when we looked at earnings in these states, it didn't exactly line up in that way. Interestingly, we saw the highest earnings in the states that have no explicit laws. So it's hard to tell if this is part of the reason for those, for the patterns of variation in MAs and of substitution. It's hard to tell. But there is something interesting here, and it's certainly relevant to policy and those who think about, well, what really makes the most sense in the general theme of having providers practice at the top of their license, which we tend to think is a pretty good thing as healthcare becomes more integrated and more focused on quality and accountability. Okay, and I think that is where I am ending. But I'd like to point you to the larger write-up, the issue brief on the website that is discussing this. And we should have more to come in the future. And now I think we're going back to Christy, or we might just go right into Rachel. Let's see.
Thanks, Dave. And we want to introduce Rachel, and then we'll get started with her presentation. Okay. Just as a reminder, we'll take all the questions at the end of this coming presentation. So if you have a question, you can go ahead and type it in the question bar, and we'll get to it as we can. Our second presenter is Rachel Willard Grace. She is the research manager in the Center for Excellence in Primary Care at the University of California, San Francisco. She specializes in rapid cycle action-oriented evaluation And among the projects she's currently managing is an evaluation of primary care transformation across 20 sites in San Francisco and several randomized controlled trials of health coaching in the primary care setting, which she will be discussing today. Rachel has a master's in public health from the University of North Carolina, Chapel Hill, and prior to joining the CEPC, Rachel was the executive director of a free clinic and worked as a public health researcher with an interest in organizational culture and change. Today, Rachel will present recently published data regarding the cost effectiveness and quality outcomes of using medical assistants in the role of health coaches in a primary care setting. And I'll make Rachel the presenter and we will get started.
Great. This is Rachel speaking, and I just want to confirm that people can hear me and see the screen.
I can.
Christy, you can. Great. Super. Wonderful. Well, let me go ahead and get started. So I think this segues really nicely from what Dr. Auerbach was speaking about, because our goal with our randomized control trial was to examine one model of a more robust, enhanced medical assistant role within the primary care setting. And specifically, we wanted to understand whether medical assistants working as health coaches could help patients with uncontrolled diabetes, hypertension, hyperlipidemia to better control their conditions. Oops, let me see if I can advance my own slides here. Here we are. And just as a quick recognition, for those of you who know work by Dr. David Thom and Dr. Ellen Chin, they were the principal investigators of this study, along with a number of other co-investigators that you may recognize and a great research staff. And this was funded by the Moore Foundation. So as a quick introduction before we get into our model, I just want to introduce you to a patient from the study. This is not her real name or picture, but I think that her case is illustrative of many of the patients that we encountered. Senora Rojas is a 59-year-old Latina woman with diabetes. She's missed 3 of her last 5 medical visits in the last year. When she comes in, she's run out of her medications. Her last hemoglobin A1C in April of 2013 was 10.4. For those of you who are familiar with this, this means that her diabetes is not well controlled at all. Because she was out of her medications again, her provider didn't want to intensify the dosage until she was taking them regularly. And the nurse has attempted to call her twice since that appointment, but she does not pick up her phone. So for many of you working in primary care, this is a very familiar scenario. It's very easy, particularly in low-income settings in the safety net. We often find that it's very easy for patients to fall out of care for a wide variety of reasons. And I'll often ask audiences, what they think may be going on with Senora Rojas. And the answers we get are usually everything from she doesn't take her diabetes seriously, she's doesn't know the importance of her medication, she's facing obstacles like finances or transportation. Maybe she has coordination of care issues. So there are a great many reasons why Senora Rojas may be facing some of the challenges that she is. Now, health coaching as a model has been examined in a number of different settings, and medical assistants as people to deliver health coaching is a popular model, and that model is spreading. There are some encouraging early results that have suggested good clinical outcomes, but there has not or had not previously been a large randomized evaluation to show that it works. And while we know that the principles of coaching work, most of the research out there has been done, for example, with RNs or with other members of the care team, pharmacists or others. And so we really wanted to understand, given the fact that medical assistants are a growing workforce and they're increasingly being used in these roles, is this a group that is able to successfully deliver a health coaching model? So we did conduct a randomized control trial, and this was a medical assistant health coaching. We worked at 2 primary care safety net health centers. And again, these were patients who had uncontrolled diabetes, high blood pressure, and high cholesterol. We wanted to find out whether these patients had better health outcomes than patients without a health coach, whether health coaches affected the patient experience, and whether they affected the clinician experience. Christy also alluded to looking at their effect on cost. And I'll mention that we didn't, I didn't include slides to discuss that explicitly, although I can share some results of what we found with our cost analysis as well. A few special things about our models. First of all, these were medical assistants embedded within the clinic. They stayed in the exam room during the medical visit, and so they were able to listen in on what the conversation was between the provider and the patient. They worked with the same patients for 12 months, which meant that they knew those patients well. And they had the opportunity not just to see patients during visits, but also to follow up with them between visits. Our intervention model essentially had 4 primary components. So the medical assistant at the beginning of the day would just have a quick check-in with the PCP, just say, I'm going to see your 10 o'clock patient. Is there anything you'd like us to talk about before the visit? They would meet with the patient prior to the visit to go over their medications, determine whether there were some that they weren't taking or were not taking correctly, to identify the patient's priorities for the visit, and to go over lab results. As I mentioned on step 2, they would stay there during the visit, and then they would stay afterward for a post-visit. So they would do what we call closing the loop, or what many also call teach back, of ensuring that the patient could describe in their own words what had happened during the visit. And then they met with patients between visits as well and followed up with them. So as I mentioned about, I may not have mentioned, about 440 people enrolled in the study. And they were randomized to receive a health coach or usual care. All of them had access to all of the resources available in the clinic. And that included, I should mention, diabetes educators and chronic nurses, and diabetes classes were available to both arms of the study. Both sites had integrated behavioral health teams that were available to both arms. So the only difference was the addition of a health coach to the care team for those patients assigned to the health coaching arm. And after 12 months, we again did a survey and measures including hemoglobin A1C, systolic blood pressure, and LDL cholesterol. Really briefly assessed about 3,000 people for eligibility, found about 650 who were eligible, and enrolled about 67% of those. Of those patients who were enrolled in the study, 86% completed a 12-month survey. Just a couple of quick things about the demographics. We did not find differences between the coaching and usual care arms. Note that we had a large population of people who were born outside the United States. And that if you know San Francisco, you'll also recognize that having 60% of your population that makes under $10,000 a year in San Francisco means that they are very low-income patients. And then a large proportion of people who are either Latino or African American. Again, across these 2 arms, we had about 60 or so percent that had type 2 diabetes. You'll notice the average body mass index puts them in that category of obese. And for those who qualified for the study based on a high hemoglobin A1C, LDL cholesterol, or systolic blood pressure, you'll notice that their control was actually pretty highly out of control. So for example, our threshold for hemoglobin A1C was above 8, and we had an average of about 10. As we looked at our outcomes for this study, our primary outcome was this composite measure. In all of the subsequent graphics, what you're going to see is that the red bar represents the health coaching group, and the black bar represents the group with no health coach. So in this case, reaching the composite goal meant that for any of the measures for which the patient was high at baseline, did they reach at least one of those goals at 12 months? And you'll see that for the health coaching arm, it was about 46% reached goal compared to about 34% in the usual care arm. Our most dramatic difference was among those patients with diabetes, looking at their hemoglobin A1C. And About half of our health coaching patients reached their goal for hemoglobin A1C compared to just over a quarter of those without a health coach. And again, all of the results, unless I mention otherwise, all of these results are statistically significant. Looking specifically at LDL cholesterol, if we looked at our overall sample on the left, you'll see that we did have a greater proportion of patients reaching that goal, but that did not reach statistical significance. However, at Site A, looking at those bars on the right, Site A had about 75%, about 3/4 of our patients, was a much larger site. At that site, we did reach statistical significance with about 42% of our health coaching patients reaching goal compared to 25% of usual care. Systolic blood pressure was a different story. We did not find a statistically significant difference between our arms in regard to their success at reaching their goal for systolic blood pressure, and we don't fully understand the reasons for that. In addition to clinical outcomes, we also looked at a couple of measures of patient experience. And one of the measures was looking at the percentage of patients who would definitely recommend either their provider or their clinic to friends or family. At baseline, there was no difference between these groups. At 12 months, there was a higher proportion of our health coaching patients who would recommend both the provider and the clinic to friends or family compared to usual care patients. And for those of you who are familiar with the Patient Assessment of Care for Chronic Conditions, the PACIC, it's used as a measure of chronic care quality. And this is a 20-item scale looking at several different components of the quality of chronic care delivered. What you'll see on this slide is that there are, for both the health coaching and the usual care patients at baseline, looking at the light gray bar, the average score was about the same for both. It was right around the 3. At 12 months, we looked at the change that happened at 12 months. For the group in usual care with no health coach, there was really no change. That score was the same. Whereas for the group with a health coach, the score increased by almost a full point, so almost 20% of that scale. And again, that was significant. And finally, we wanted to understand a little more about the provider experience. So we did this using a couple of means, and one of them was conducting a survey. So each providers received a survey for each patient in the study that included 7 items, and that survey was specific to a visit that occurred at least 6 months into the study. So for example, the survey would ask, compared to your average visit, how demanding would you rate this visit in terms of the amount of effort required? And then there were 6 items from a different scale asking questions such as, I found this patient easy to interact with, or I felt comfortable dealing with this patient's problems. So looking at that first question, and actually let me preface this by saying not every one of those questions was statistically different between our health coaching and usual care arms. It was always better for the health coaching patients, but there were only a couple of questions that really reached significance. One of them was this question, and that was compared to your average visit, how demanding would you rate this visit in terms of the amount of effort required? So in this case, better is lower. You'll see that our health coaching patients, the providers rated the degree of demandingness of the visit as lower than in the usual care. And then conversely, if we looked at the clinician rating of the medical visit, the overall score, again, was slightly higher for the health coaching patients but did not reach significance. The one question that did was this question about being able to spend sufficient time with the patient. And in that case, that was higher for the health coaching arm than the usual care arm. And our findings from the qualitative study also supported this. Every study has limitations, so just a few of ours. First of all was generalizability. We were working in a population where patients had very low income. Many were first-generation immigrants. We worked with a group of health coaches that were very highly motivated and interested in being health coaches. Our participants weren't blinded to their assignment. They knew whether they were receiving health coaching or usual care. And there was, we did randomize at the level of the patient, so it's not impossible that we could have had some carryover effect that would have occurred as, for example, providers use techniques that they saw working with their health coaching patients and use them with other patients, or patients talk to each other in the waiting room. But in brief, I think that this adds some support for the potential of new roles for medical assistants. Patients who received health coaching from these medical assistants did have improved clinical measures, particularly for glycemic control and cholesterol control. And that is something that holds some promise, because it means that this type of model could provide a financially viable option for the provision of self-management support in primary care. Really briefly, just going back to Senora Rojas, we started with her case. And I wanted to just share with you what happened from the health coach's perspective. And the health coach said, and one time she came into a medical visit. I noticed she had a little plastic coming from her hearing aid. And I asked, can you hear me okay? She said, no, I've had this hearing aid for maybe 5 years, and it's not working as well as it used to. Her doctor didn't even know about this, which is weird. She's probably been seeing him for a year or two, and he had no idea. And her doctor's very soft-spoken. And at that time, her A1C was out of control. The doctor wanted to start her on insulin, and she said, I don't want to. We could do this. I could bring it down. And if you remember, this patient at the beginning of the study had a hemoglobin A1C of 10.4, and this was her final. So I'll just mention in passing, before I hand this back off to Christy, that we love to share our resources. So if this is something of interest to you, please visit our website. We've posted our protocol, most of our forms, many examples of training, training videos or training curricula are available on that website. And with that, Christy, maybe I can turn this back over to you.
Perfect. Thank you, Rachel.
My pleasure.
All right, great presentations today, and we have plenty of time for questions. We actually may get finished a little early today, depending on how it goes, but we'll see. If you have questions, feel free to add them into the questions area of the GoToWebinar toolbar. We have a few, so we'll get started. Dave, this one is for you. What do you think is the future for medical assistants? Specifically, will medical assistants add value to organizations who will increasingly be held accountable for quality and cost?
That's a great question. I think so. I think they will. I mean, one piece of evidence I would bring to that, and I didn't include this in my talk, but some other folks have looked at the staffing of some of the more advanced, successful primary care organizations, like such as those who are in the Medicare, a special Medicare payment model that's somewhat of a trial, testing new models to handle global payment and to improve quality. And you'll find more medical assistants being used in those kinds of advanced models of primary care. And I've seen some of this in other data that I've looked at as well. So I would say that, you know, when we look at some organizations that probably represent where we're going in the future, they have already started to use a greater proportion of medical assistants and other folks in their workforce mix. So that just suggests to me a trend that as we move away from fee-for-service payment and towards the kind of quality, value, accountability, and as Rachel was showing, you know, in the past you might not have had a financial payoff to improving the quality of care of a set of patients. You know, it was a nice thing to do, but maybe not a priority in the way. But now, more and more, these kinds of outcomes, exactly the kinds of outcomes that she showed, are being built in right into the kind of payment that organizations receive, whether it's from Medicare, private payers. It is just becoming more and more prevalent where practices have to pay attention to those kinds of things. And as more evidence comes out that medical assistants seem to be successful at improving those outcomes, and it's not really the most highly paid workers, although that might increase as their value goes up, I do think that this is a growing trend towards the future.
Great. I have a quick one I can answer. Will this webinar be available for review later in the week? It will be available for review. We're recording it today. I'll hope to have it posted by the end of this week, if not for sure by next week. Okay, I think this is a clarifying question for Rachel. What regions of the U.S. did this take place? I'm assuming they're asking, were the 20 sites all in the San Francisco area?
Thank you. I apologize. I didn't make that very clear. For this particular randomized control trial, there were actually 2 sites. Both were safety net primary care clinics in San Francisco. So I think that's a very relevant question, and among other cases in which this ought to be tested further, it's certainly looking at other environments. What I will mention is that as a kind of a follow-up to this study, we have, and actually to back up a bit, our training arm of our center actually does a tremendous amount of training across the United States, and a lot of that is in rural settings where, both rural settings and other regions of the United States where many times medical assistants are the best available workforce in which to carry out some of the functions such as navigation and care coordination and self-management support. So certainly we have seen this anecdotally be effective in other areas, and I'll mention that we recently trained a number of clinics as a follow-up to this study in very rural areas of California. This was something of great interest to them because they just simply don't have access to certain other kinds of resources such as certified diabetes educators or others who might otherwise be performing some of these functions.
Okay, great. I have one more for you, Rachel. MAs seem to be less costly than RNs, which is positive for organizations, but do people feel positively or negatively towards MAs? And did your research specifically identify the public's reaction or satisfaction with their MA that they saw?
That's a wonderful question, because certainly in order to scale up some of these new models of care, there really has to be acceptance. And I'm going to kind of define that question a little bit more narrowly than talking about the public and talk specifically about the patients who were served through this. Patients were very, very eager to have a health coach. They knew the qualifications of that health coach, and that was the draw for this study. We did provide small incentive payments, but just to speak from the recruitment perspective, people were in it because they wanted that support, and they became very connected to their health coach. It was, I think, a very important resource for them. When we finished our study, the first thing that we did was go back to the clinics and present both to the staff and to the patients what we learned before we ever went out on the road to share this in conferences. And I'll mention that at one of our sites, which had maybe about 300 people, we had about 70 people show up to hear the results, which was, in my experience, unprecedented. And they also spent some time kind of sharing their experiences within that forum of their experiences within health coaching, which were overwhelmingly positive. So among the patients, this was something that, to be quite blunt, they really didn't care who was providing the support as long as they were getting it. From the perspective of the staff at these sites and the providers, I think it took a little bit of work to really communicate what medical assistant health coaches could and could not do, what was appropriately within their training and their level of practice and what was not. And then once that was clear, I think that the response that we got from staff and providers, again, was very positive. So our qualitative interviews of providers, we found a lot of really positive report backs about their experience working with medical assistant health coaches. So what I would say is that I think every environment is a little bit different. Certainly within this environment, there was a very high level of acceptance for having medical assistant health coaches, and actually both staff and patients advocating to try to keep them on staff after the study had ended and the funding for those positions had ended as well. So I think that certainly it can have a very high level of buy-in. So thank you for that question.
Okay, great. Dave, do you think that the demand for MAs will increase in the future? And then similarly, do you think that the wages or earnings of MAs will increase, or will the pressures of the new payment models squelch wage increases?
That's a very good question too. Yes, I think the demand will increase. And as to what might happen to wages, you know, as thinking from the point of view of Econ 101, it should. They should certainly go up. But healthcare is never really as simple and as you might think it would be. So I guess the wages, it'll partly depend on if there are even other less trained personnel who could do some of the things that MAs do, and I haven't thought much about that. But I imagine that as practices and organizations find that the roles that MAs are playing, especially like we saw today, are more and more critical, I imagine that probably not only will the wages rise and will the demand rise, but I could imagine that the educational requirements and some of the training programs will be a little more standardized, probably longer and probably more clarified and standardized across the states. And I don't know that for sure, but it's certainly possible, and it's something that you've seen in other professions as well, that start out sort of like the Wild West, and then as you have more and more demand for some of those roles and a larger group of people doing them, there starts to be more interest in kind of having something be more standardized and probably moving towards the direction of a longer required training period, which will probably be reflected in a higher wage as well.
Great. I know that was a tough question to answer.
It is. A lot of speculation.
Okay, back to Rachel for another one. Rachel, are you planning any future research on MAs? For instance, would it be interesting to compare different types of professions as health coaches, MAs versus RNs or certified health coaches, and evaluate the outcomes?
Sure. I think that that certainly is one direction that you could go with research, is really trying to find the people best equipped. I'll tell you quite bluntly, that's not the direction that's of greatest interest to me, because quite frankly, at different areas of the country, different people are available. What we really would like to see is these basic services being provided by the people that in each setting are best equipped to provide them, and ensuring that the training and support is available, whatever that model may look like. We certainly know that this can be very well conducted by health educators, by RNs as well, and we do want to see all of those individuals working to the highest, to their highest ability of their capabilities and their training, and that's going to look a little different in different scenarios. What I would say was perhaps more an interest of me personally would be looking at different conditions to try to understand whether this type of a model may be appropriate for other types of conditions, such as, say, pediatric asthma. We're doing a study right now around health coaching for patients with chronic obstructive pulmonary disease. And so that is one direction that I certainly would advocate for. I think the other thing that is a real need we're hearing right now is just more in the way of implementation research of how to scale this up. So we have some examples where it's worked very well, and for a variety of reasons, including things like payment models and other things within our landscape that are shifting, there are often some challenges as well to implementation. So one thing I would just add to that is that I think that there's, in addition to this research on the efficacy of health coaching, there's a real need to understand more about implementation. And I think there's a lot of opportunities, so I just strongly encourage those who are interested in this. I think a lot of those questions are very valuable and are well worth answering about the effectiveness in other settings, for example, or with other players within the healthcare team.
Okay, great. I have one more clarifying question. What national certification or credential did the MAs have in each of the 2 research sites, i.e. CMA, AAMA, RMA, etc.? I believe that's for you.
Sure. Well, I'd be glad to answer that, and that's a great question. As some of you may know, certification of medical assistants is actually not very common nationally. The last I looked at this, and this is a couple of years old, only about 15% of people working as medical assistants in the United States were certified by a national agency. There is a higher number now that are receiving diplomas for medical assisting schools. And in our case, we chose to employ people who had diplomas but were not certified. They did not have a national certification. There are a number of different options for certification. At the last time I looked at those, none of those really included capacities or areas of skill that were really focused on medical assistant or on health coaching skills. So that kind of training came on top of what they had learned in their medical assisting program. So we have about a 40-hour program that we use to train medical assistants. And so that I think it's wise to caution that that's not an automatic skill set of people coming out of medical assisting programs today. And it will be interesting to see as some of these programs develop how that influences the medical assisting curriculum as well. And thank you for that question. That's a great point.
Great, thank you. Just as one last kind of closeout question for both of you, do either of you have a question for the other presenter that you'd like to ask about their presentation?
Yeah, I do. Sure. Thanks for the opportunity. Actually, I thought it was very interesting, the results when you were showing some of the impacts of the health coaches with. I don't remember them all now, but I think there were significant impacts on several of the domains, like the cholesterol, but not on the blood pressure. And I wondered if there's anything more you know about that. Like, was that surprising, or is it that you sort of know what kind of intervention they would have making and how it might have affected either of those outcomes, and just if there's any deeper thoughts on the mechanism of how that might have worked out, and perhaps you just don't know why they worked out that way, which is very possible in research.
Yeah, that's a great question, David, and I think we don't know exactly what the mechanism is, but we certainly have spent hours and hours speculating. And so I think, a number of the factors that we think about when we think about blood pressure and look at the research on better control of blood pressure is that often the interventions that seem to be highly effective for managing blood pressure involve very close monitoring and titration of medications, really trying to optimize the medication management of high blood pressure. And so I think certainly one factor could be that as the health coaches were fitting into existing systems where a lot of those mechanisms really weren't in place, they had very limited ability to facilitate that process. They certainly could identify when the blood pressure was high and make sure that was on the agenda for the visit, but they couldn't necessarily do a lot to help speed the titration of medications, as you might find in some of the pharmacist-based programs or the RN-based programs that have been successful in managing this. So I think that's one factor. I think another factor is certainly that blood pressure is somewhat more volatile measure, and there may have been other things that were influencing it aside from long-term management that we just failed to impact. So I don't think we know exactly, but I think that's certainly one set of factors that could have influenced.
Mm-hmm.
And if I could ask you a question as well, I wonder with the, it was really exciting to kind of see the relationships between the roles of or the number of medical assistants working in, say, the scope of practice laws or the relationship with LPNs. If you could add any question to future surveys that would help you to explore in greater depth the role of medical assistants, what might that be?
Oh, that's a great question. I mean, the survey that this data derives from is pretty fixed and set in stone. So it's a little bit hard to imagine impacting the census. But some of the things that we struggle with and would love to know more is, for example, more granularity around the industry, the work setting. You know, it's the kind of thing that you might have in where each where associations, like for a given profession, will survey their members and learn much more detailed, you know, fine grains. I would love to know, you know, are these folks working in large health systems and small one-off practices? That would really be nice to know. And or even are they working in primary care settings or other settings? And so, you know, there will be, even if we can't influence the census that much, there are quite a few data collection and survey efforts going on in the workforce world where it would be great to bring in some of the insight that we might get from there into some of these questions about substitutability and earnings and effectiveness. So that's probably one of the most important ones, I would say.
Wonderful. Thank you.
Okay.
Okay, great. Well, we actually made up a lot of our time there. We had a lot of questions. So with that, I would like to say thank you to our presenters for being a part of our webinar today. You did an excellent job. We will be concluding our webinar series for the spring with this one, but we will return with our theme series this fall, most likely focusing on value-based healthcare and the health workforce. So it's going to be a really exciting series of webinars that we have lined up for that. So we hope you will be back, and stay tuned to our website over the summer for more exciting issue briefs and data briefs and announcements as we head into the rest of the year. Thanks, and have a great day.
Thanks, Christy.